A young adult presents with severe acute abdominal pain and a history of joint aches. I am showing you the abdominal radiograph. Describe the findings.
Right, so the abdominal radiograph demonstrates several classic features of sickle cell disease. There is mild, diffuse osteosclerosis and coarsening of the trabeculae throughout the visualized skeletal structures. In the lumbar spine, there is depression of the central vertebral end plates, creating characteristic H-shaped vertebrae. In the right upper quadrant, 3 well-defined radiopaque densities are projected outside the right kidney, consistent with pigment gallstones. The left hip shows subchondral sclerosis and flattening of the femoral head, indicative of avascular necrosis. Additionally, there is a small, shrunken, and densely calcified spleen, representing autosplenectomy from recurrent splenic infarctions.
What is the pathophysiology behind these skeletal and abdominal findings in sickle cell disease?
Sickle cell disease is an autosomal recessive hemoglobinopathy where a single nucleotide substitution in the beta-globin gene causes abnormal hemoglobin S. Under conditions of low oxygen tension or dehydration, hemoglobin S polymerizes, causing red blood cells to deform into a sickle shape. These rigid cells increase blood viscosity and occlude microvascular beds, causing local tissue ischemia and bone infarction. End plate infarctions of the vertebrae lead to the central end plate depressions that form H-shaped vertebrae. Repeated microvascular thrombosis in the spleen leads to progressive tissue necrosis, fibrosis, and eventual autosplenectomy. Chronic hemolytic anemia causes marrow hyperplasia, which radiographically presents as coarsened trabeculation and diffuse osteosclerosis.
I am showing you a chest radiograph and an intravenous urogram from the same patient. Describe the findings and how they relate to this disease.
The chest radiograph demonstrates diffuse osteosclerosis of the ribs and clavicles, H-shaped thoracic vertebrae, and marked cardiomegaly, which is a physiological adaptation to chronic hemolytic anemia. The intravenous urogram shows a sloughed renal papilla within a calyx, representing renal papillary necrosis. This complication occurs because the renal medulla is hypertonic and hypoxic, which promotes sickling, microvascular occlusion of the vasa recta, and subsequent ischemic necrosis of the renal papillae.
Discuss the key differences between bone marrow infarction and osteomyelitis in sickle cell disease and how they are investigated.
Differentiating between bone marrow infarction and osteomyelitis is a common diagnostic challenge in sickle cell patients, as both present with acute bone pain, fever, and leukocytosis. Radiographs are often normal early in both conditions. Magnetic resonance imaging can demonstrate marrow edema, but cannot reliably distinguish acute infection from acute infarction. Nuclear medicine scintigraphy, using a combined technetium-99m sulfur colloid scan and a gallium-67 or indium-111 labeled white blood cell scan, is the most specific imaging technique. An area of decreased uptake on sulfur colloid bone marrow scan that is gallium or white blood cell negative indicates a simple marrow infarction, whereas congruent increased uptake of the infection tracer confirms osteomyelitis.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with prior films to assess the stability of the H-shaped vertebrae and femoral head avascular necrosis. I would suggest obtaining a right upper quadrant ultrasound to confirm the presence of gallstones and evaluate for acute cholecystitis. If bone infection is clinically suspected, I would recommend a combined bone marrow and white blood cell scintigraphy or a dedicated spine and hip MRI to evaluate for osteomyelitis or joint effusion. Finally, I would document the findings, alert the referring clinician to the risk of renal papillary necrosis and autosplenectomy-associated sepsis, and refer the patient to hematology and orthopedic surgery for ongoing management.